The initial treatment for mantle cell lymphoma is dependent on patient age and comorbidities, where in younger patients, we usually use intensive induction therapies, which there's a handful of different regimens which have been shown to have similar outcomes, followed by autologous stem cell transplant, and then consideration of maintenance with CD20 antibody rituximab. In patients who are older or not candidates for a more intensive approach, we often use a chemoimmunotherapy approach with a rituximab, the CD20 antibody, combined with one or more chemotherapies. The VRCAP regimen is a regimen that uses a proteasome inhibitor, bortezomib, in combination with chemotherapy and rituximab in the frontline treatment of mantle cell lymphoma. And there is an oral immunomodulator, lenalidomide, which is also has a small study, has looked at it in frontline treatment in combination with rituximab, which may be appropriate for a small subset of patients, although this is not an FDA-approved regimen. When a patient first presents to you, there are many different options for treatment. About 80% of mantle cell lymphoma patients will require treatment at presentation, but about 20% are going to be able to undergo observation. This usually falls within two main categories of patients. One would be the patients with leukemic non-nodal disease, so that have circulating lymphoma cells, bone marrow, splenic involvement, but not much in the way of lymph node disease. And the other is patients who can be associated with a number of factors, but it's often patients with low tumor burden disease, normal LDH, good performance status, no symptoms from their disease. And these patients can be observed without therapy. Largely, most patients, as I said, are going to need therapy. About 80% will need therapy when they're diagnosed. The majority of mantle cell is advanced stage at diagnosis, and so a combination of chemoimmunotherapy is going to be the most utilized approach. There is a small percentage of time where you'll see very localized disease, stage 1 disease, where radiation or chemotherapy in combination with radiation is an appropriate choice. Typically, when patients present to me, I look at two large things: their age and their performance status. So younger patients who can tolerate more intensive therapy are going to get approached with a more intensive chemotherapy approach, such as the DHAP or the Nordic regimen, followed by autologous stem cell transplant. That's because this has been shown to prolong progression-free survival, and there's even been an overall survival benefit shown when rituximab maintenance is used after transplant. He takes these patients and puts them into significantly longer remission. In patients who are older or have multiple comorbidities, they oftentimes are not going to be able to tolerate such an approach. And so they're, outside of a clinical trial, they're looked at as somebody who's going to use a less intensive chemoimmunotherapy regimen most of the time. Bendamustine rituximab is the regimen I utilize in the majority of patients, which has very high response rates, high complete remission rates, and reasonable progression-free survival. Other chemotherapy options include R-CHOP and the VRCAP regimen. There's some data on RBAC, which adds a low-dose cytarabine to the bendamustine rituximab regimen. And then there is a small study that showed rituximab lenalidomide in the frontline setting, induced pretty good remissions with the good 5-year PFS, but again, this was a small amount. There is emerging data also with the combination of rituximab and the oral BTK inhibitor ibrutinib in the frontline, but again, these are not FDA-approved therapies at this time.